Hi there, my highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for very high impact pharmacotherapy services. So I humbly urge you all to sit back and spare me part of your very precious time to share with you some useful tips which may prove very handy in your line of duty. So I welcome you all to part 110 of our pharmacotherapy MCQ series, measuring infectious diseases. Welcome. Our first question reads, your infectious diseases consultant discharges Mr. YJH, a 67-year-old male patient who was admitted to the general medical ward due to a mitral valve endocarditis caused by methicillin-susceptible Staphylococcus aureus on nafcillin, which would be administered at a dose of 8 grams via continuous infusion over 24 hours. My question to you is, which of the monitoring strategies would be the best or the most appropriate for Mr. TJH's antimicrobial regimen? Do you choose to pay attention to CBC and Chem7 on Mondays, Wednesdays, and Fridays, and liver enzymes weekly? Or would you choose to pay attention to Chem7 and CBC weekly? Or would you pay attention to Chem7 and CBC on Mondays, Wednesdays, and Fridays? Or would you choose to pay attention to Chem7 and CBC weekly and liver enzymes on a weekly basis? I'll give you 10 seconds to choose the correct answer. D is the correct answer here. Pay attention to CBC, Chem7 weekly, and even liver enzymes weekly. The IDSA outpatient antimicrobial therapy guidelines provide guidance regarding commonly used agents, and CBC monitoring is necessary for nafcillin, since leukopenia and thrombocytopenia can occur in the course of therapy using this agent, especially with long-term use. Remember that. And acute interstitial nephritis can also occur with beta-lactams, and was the reason methicillin was removed from general clinical practice guidelines. I'd like to emphasize that penicillinase-resistant penicillins, such as nafcillin and oxacillin and carbapenems, are the most likely to be associated with hepatotoxicity. Therefore, weekly monitoring of liver enzymes is recommended when using these agents. Let's move to the next question, please. And it reads, Master KOK, a 7-year-old boy, is brought to a pediatric accident and emergency by the mother with a sudden onset sore throat and fever without a cough. On physical examination, significant bilateral lymphadenopathy with some small exudates to the tonsillar pillars are noted by the pediatrician. And the labs are done. A rapid antigen detection test comes back positive for group A streptococcus. Now, on further probing the mother appears disheveled, that is messy and unkempt. She isn't interested in what the pediatrician has to say. She has no medical insurance cover, but has received 2 previous prescriptions for amoxicillin for past ear infections. Wonder whether she had them filled or not at the pharmacy. Now, the pediatrician is concerned about the mother's ability to buy prescribed medication and whether or not she will administer the same to Master K or K until the completion of the prescribed dose. On probing further, you establish this kid has no known drug or food allergies. So my question to you is, which of the options listed below would be the most appropriate in this clinical scenario? Would you choose to treat this young man with clindamycin marketed as Cleocin or Dalacin? Or would you choose to treat with penicillin VK? Or would you choose to administer benzathine penicillin G marketed as Bicillin long-acting via the IM route? Or would you choose to treat with oral erythromycin? I'll give you 10 seconds to choose the correct answer. I would settle for C, benzathine penicillin G, marketed as Bicillin long-acting via the IM route. Remember, benzathine penicillin G is a long-acting beta-lactam which is monitored once and as an IM dosage form. Now, this start dose will treat pharyngitis due to Streptococcus pyogenes, which belongs to the group A Streptococcus, and it will ensure that Master K or K receives adequate treatment in this clinical situation to protect him from developing rheumatic heart disease and post-streptococcal glomerulonephritis, which can occur 2 weeks post-infection. Remember that. An important consideration to keep in mind when using this option is any past history of problems taking beta-lactam antibiotics, and gladly we were told there are no allergies in that regard. I'd just like to add that generally, if patients have been treated with another antibiotic, such for example amoxicillin, then the use of a long-acting beta-lactam is likely to be safe. Now, this is clinically relevant since benzathine penicillin G can stay around, can linger in the body for several days after administration. Now, if an adverse reaction were to occur after its administration, the patient would continue to be exposed, thereby worsening the adverse drug reaction. Now, this patient hopefully has received 2 prior courses of the prescription of amoxicillin without reported allergies. So we hope and pray we are safe. Now, while other options are technically treatment options, those ones listed up there, they all require several doses of administration throughout the day and for a duration of about 10 days. And this isn't likely to be conducive to a lady like this one, who may not be dedicated enough to complete the treatment course. She may not help the kid be adherent to the regimen. So a start dose would be the best bet. Let's move to the next question, please. And it reads, Mrs. TWG, a 35-year-old female, presents to your hospital with a chief complaint of malodorous vaginal discharge. She has suprapubic discomfort and she has itching and dysuria, which has been going on for the past 2 days. The pH of her vaginal discharge is 5. It's slightly acidic. And Mrs. TWG is determined to have Trichomonas vaginalis. So my question to you is, which of the therapeutic options listed below would be the most appropriate for Mrs. TWG now? Would you treat her with the That tablet of cotrimoxazole double strength taken orally twice daily for 3 days, or would you opt for tetracycline 500 milligrams every 6 hours for 7 days, or would you choose to treat with the 2 grams of metronidazole taken orally start, that is a single dose, or would you settle for nitazoxanide 500 milligrams taken orally twice daily for 3 days? I'll give you 10 seconds to choose the correct answer. So I would settle for metronidazole, 2 grams orally start. Now metronidazole is a common treatment for Trichomonas vaginalis and can be administered as a start dose of 2 grams. And I'd just like to add that nitazoxanide is commonly used for cryptosporidium and giardiasis, infections caused by Giardia lamblia. And tetracycline can treat Balantidium coli infections which occur from pig feces. And then cotrimoxazole there as alternative A is used for cyclospora and microsporidia. Those are the protozoa infections it can treat, not Trichomonas vaginalis. So let's move to the next question, please. And it reads, which of the statements listed below best describes the type of response provided by beta-lactam antibiotics and vancomycin in the context of treating bacterial infections in the hospital setting? Is it true that they are competitive inhibitors of growth? Are they concentration dependent in their killing? Do they have a time-dependent killing? Or are they bacteriostatic in effect? I'll give you 10 seconds to choose the correct answer. They have time-dependent killing. Both of them have time-dependent killing. I would like to start by saying that beta-lactams and vancomycin are well-known inhibitors of bacterial cell wall synthesis that makes them bactericidal in most cases, not in all. Now, they are both time-dependent killers. That is to say, they only have to achieve a certain steady-state concentration for a period of time to exert their beneficial effect. Now, when they reach this level, giving more or higher doses doesn't improve efficacy or the therapeutic effect. The exception would be in the presence of more resistant bacteria, for example. And even then, once certain drug levels or concentrations have been achieved, there is no greater degree of killing when you go higher than that dose. So what is important is to maintain therapeutic serum concentrations over a long or extended period of time for the effective killing to be attained. Let's move to the next slide, please. And it reads, Mrs. R.A.O., a 75-year-old female patient, is admitted to your medical ICU and she develops a nosocomial intra-abdominal infection. She has no known drug or food allergies. Some of her vitals include a body temperature of 38.3 degrees centigrade, a heart rate of 114, it's pretty high, and a respiratory rate of 26. So my question to you is, which of the options listed below would be the best to monitor goal-directed resuscitation? Would it be pulse pressure variation? Would it be central venous pressure? Would it be mean arterial pressure? Or would it be central venous oxygen saturation? I'll give you 10 seconds to choose the correct answer. Mean arterial pressure it would be. Now the surviving sepsis and septic shock guidelines recommend the mean arterial pressure, what we call MAP, as the optimal method to evaluate initial resuscitation, since MAP is the driving pressure of tissue perfusion. Now early goal-directed therapy use a series of goals including central venous pressure, central venous oxygen saturation, abbreviated as SCVO2, and this approach has now been challenged following the failure to show a mortality reduction in 3 subsequent large multi-center randomized clinical trials. In addition, the use of a CVP alone to guide fluid resuscitation can no longer be justified because the ability to predict a response to a fluid challenge when the CVP is within a relatively normal range is limited. That normal range is, I think, 8 to 12 millimeters of mercury. Now, the use of a pulse pressure variation to predict fluid responsiveness in a patient with sepsis or even septic shock demonstrated a sensitivity of 0.7 with a 95% confidence interval of 0.61 to 0.81, and it demonstrated a specificity of 0.91 with a 95% confidence interval of 0.83 to 0.95. Now the quality of evidence here was low due to imprecision and the risk of bias. Now, targeting a MAP of 65 has been associated with less risk of arrhythmias and mortality than a higher goal of, say, 85 millimeters of mercury. Just as a by the way. Now, those many words justify why C, mean arterial pressure, would be the best bet in this particular question. Let's move to the next question, please. And it reads, which of the lipid-lowering medications listed below is contraindicated in HIV-infected patients who are on protease inhibitor-based regimens due to drug-drug interactions, which increase the patient's risk of developing rhabdomyolysis? Would it be fenofibrate, marketed as Trical? Would it be gemfibrozil, marketed as Lopid? Would it be simvastatin, marketed as Zocor? Or would it be pravastatin, marketed as Pravachol? I'll give you 10 seconds to choose the correct answer. C is the correct answer. Simvastatin it would be. Now, all protease inhibitors are CYP3A4 inhibitors. Remember that. And simvastatin from that list is the only substrate of CYP3A4. Now, PK studies have revealed that simvastatin blood concentrations can be increased by over 3,000% if co-administered with protease inhibitors, especially saquinavir. Now, it is also known that the risk of rhabdomyolysis is drug concentration dependent. Now, while pravastatin can also interact with the PIs, it isn't to the same degree of severity as simvastatin or even lovastatin, which is not in that list. And I would like to add that gemfibrozil and fenofibrate aren't known to interact with or to cause this adverse drug event. So those many words make simvastatin or Zocor the correct answer. Let's move to the next question, please. And it reads, your infectious diseases consultant admits Mr. JMP, a 77-year-old male patient, to to the medical ICU following a diagnosis of VAP due to methicillin-resistant Staphylococcus aureus. And he establishes this patient is allergic to penicillin, and the last time he received penicillin, there was anaphylaxis. Currently, he takes aspirin, carvedilol, ramipril, and risperidone. So my question to you is, which of the therapeutic options listed below would be the most appropriate for Mr. JMP's treatment now? Would you opt to treat him with telavancin, linezolid, daptomycin, or would you settle for ceftaroline? I'll give you 10 seconds to choose the correct answer. I would treat this gentleman with linezolid infused over an hour at a dose of 600 milligrams every 12 hours. Linezolid, in my opinion, marketed as Zyvox, is the best option for Mr. JMP. Remember, daptomycin, marketed as Cubicin, is bound to pulmonary surfactant and is inferior to even ceftriaxone for community-acquired pneumonia. Then telavancin, marketed as Vibativ, and ceftaroline, marketed as Teflaro, lack FDA approval for HAP. In addition, telavancin can prolong the QTC interval and shouldn't be co-administered with risperidone if other options are available, because both of them prolong the QTC interval and such a patient would enter a serious arrhythmia. Let's move to the next question, please. And the next question reads, MOW, a 15-month-old boy, is brought to your pediatric accident and emergency department by the mother. He has no known past medical history, and his chief complaint today is a dry cough that sounds like a seal. Master MOW is walking around on his own as normal, but the mother says he appears, in her words, not himself. He denies vomiting and fever. He has some mild stridor sounds on lung examination and a small intracostal retractions. So my question to you is, which of the therapeutic options listed below would be the most appropriate for Master MOW now? So would you choose prednisolone at a dose of 1 milligram per kilogram orally start, or would you settle for 20 milligrams of amoxicillin per kilogram orally twice daily for 10 days, or would you settle for dexamethasone at a dose of 0.3 milligrams per kilo orally start, or would you administer ceftriaxone at a dose of 25 milligrams per kilo via the IM route start? I'll give you 10 seconds to choose the correct answer. I would treat this gentleman with dexamethasone at a dose of 0.3 milligrams per kilo orally start. Now, MOW has a classic case of laryngotracheitis, which is called croup, which affects most children, most commonly 6 months to 3 years of age, and is most commonly caused by human parainfluenza virus. It can be type 1, type 2, or type 3. Remember that. Now, since croup is caused by a virus or a viral infection, antibiotics such as ceftriaxone, amoxicillin are not indicated. So that makes answers B and D wrong. And the treatment choice, or the treatment of choice for croup, is dexamethasone at a dose of 0.1 milligram per kilogram to 0.3 milligram per kilogram. Some people even use 0.6 milligram per kilogram all as oral start doses. So answer C would be correct. Now historically, clinicians have used 0.6 milligram per kilogram orally, or even IM, or even IV, but smaller doses have been shown to be equally effective, so you don't have to go that high. Now, other steroids recommended in the management of croup include budesonide at a dose of 2 milligrams, but via nebulization as a start dose. Now, both dexamethasone and budesonide are corticosteroids, therefore they lack mineralocorticoid effects, and they will not contribute to the subglottic narrowing. Now, croup is caused by viral infection resulting in subglottic narrowing that is most commonly treated with a start dose of either dexamethasone or budesonide. So just remember that last statement. Let's move to the next question, please. And it reads, Mr. KML, a 79-year-old male patient, develops a nosocomial pneumonia during his admission to your general medical ward on day 10 following a COPD exacerbation. He has no known significant past medical history apart from the COPD. He currently takes salbutamol, theophylline, hypertropium, and he receives sliding scale insulin because of this admission. He has no known drug or food allergies, and the medical resident on duty initiates cefepime and seeks your advice as the clinical pharmacist, infectious diseases specialist, on which anti-MRSA antibiotic to prescribe for Mr. KLM. So my question to you is, which of the options listed below would be the most appropriate for Mr. KLM's management? Would you choose to treat him with tigecycline, or would you settle for tedizolide, or would you choose vancomycin, or would you opt for daptomycin? I'll give you 10 seconds to choose the correct answer. I would settle for vancomycin and infuse it over at least 1 hour. Now, the IDSA HAP/VAP guidelines recommend either vancomycin or linezolid for patients at risk of MRSA infection. Now, the guidelines state that an MRSA prevalence of above the 20% mark or receipt of IV antibiotics within the past 90 days are indications for MRSA treatment in such patients. Now, daptomycin isn't recommended as it's bound by pulmonary surfactants, so alternative D is automatically wrong, and this binding causes it to be inferior to even agents as mild as ceftriaxone for community-acquired pneumonia. Now, tedizolide is yet to get FDA approval for HAP or VAP treatment, and it isn't included in any HAP or VAP guidelines. All those many words would make me biased towards C. And we know that tigecycline has a very large volume of distribution, so even though it may be effective against MRSA, you would not obtain therapeutic serum concentrations in such sick patients, so it would not be effective as monotherapy for MRSA infections. I would like to add that total body weight should be used to dose vancomycin according to the vancomycin consensus statement. I would refer you to that statement. You can get it on the internet. I would like to emphasize that linezolid and vancomycin have been shown to have similar rates of thrombocytopenia when used for less than 14 days or equal to 14 days. And then telavancin has showed an increased risk of mortality in patients who have creatinine clearance levels of below 50 ml per minute max. So be very careful if you have to use them to treat MRSA infections in such renally impaired patients. Let's move to the next question, please. And the next question reads, Mr. FYI, a 65-year-old male patient is admitted to your general medical ward with a severe diabetic foot infection. The incidence of community-acquired diabetic mellitus foot infections due to MRSA in his area of residence is considered low. He has no known drug or food allergies, and currently he receives NPH insulin, aspirin, and sertraline. And he also receives hydrochlorothiazide after his breakfast. So my question to you is, which of the therapeutic options listed below would be the most appropriate for Mr. FYI's treatment now? Would you treat him with linezolid and aztreonam? Or would you treat him with levofloxacin and metronidazole? Or would you treat him with daptomycin and aztreonam? Or would you treat him with cefuroxime and metronidazole? I'll give you 10 seconds to choose the correct answer. So I would settle for levofloxacin and metronidazole. Now, the treatment of severe infections should include coverage against gram-positive cocci, including MRSA in locations with high MRSA rates. It should include gram-negative pathogens and even obligate and anaerobic organisms. Therefore, daptomycin or levofloxacin with or without aztreonam should be reserved for moderate diabetic mellitus foot infections. That makes answer A wrong, and even C is wrong as well. Now, cefuroxime and metronidazole is only recommended for moderate diabetic foot infections according to the IDSA guidelines. So that makes the combination of levofloxacin and metronidazole the best option in this particular case. Let's move to the next slide, please. And the next question reads, Mr. HLK, a 55-year-old male patient, is diagnosed with chronic prostatitis at today's clinic visit. He has a past medical history of hypertension, type 2 diabetes mellitus, hypothyroidism, and moderate to severe chronic obstructive pulmonary disease. Currently, he takes levothyroxine, hydrochlorothiazide, theophylline, metformin, and enalapril. So my question to you is, which of the medications listed below is most likely to be affected by Mr. HLK's being initiated on ciprofloxacin for his prostatitis? Would it be metformin, levothyroxine, theophylline, or enalapril? I'll give you 10 seconds to choose the correct answer. C, theophylline it is. I would like to start by saying that ciprofloxacin decreases the metabolism of theophylline through inhibition of CYP A1-2. And this results in increased theophylline serum concentrations, and that would place Mr. HLK at an increased risk of CNS and other adverse drug reactions. So don't co-administer the two. Let's move to the next question, please. And it reads, Master RMN, a 15-year-old boy, presents to your pediatric A&E. He has a chief complaint of facial pain on palpitation. There is purulent nasal discharge, and this has gone on for the last 3 days. Some of his vitals include a heart rate of 70, a blood pressure of 100/60, a respiratory rate of 20, and a temperature of 102.4 degrees Fahrenheit. My question to you is, which of the regimens listed below would be the most appropriate for Master RMN now? Would you choose to treat him with cotrimoxazole? Would you settle for clarithromycin? Would you settle for co-amoxiclav augmentin? Or is it true that no antibiotic is indicated since this is a viral infection? I'll give you 10 seconds to choose the correct answer. I would choose to treat this young man with co-amoxiclav augmentin. Remember, RMN has severe symptoms, which include a temperature equal to or above 102 degrees Fahrenheit, along with purulent nasal discharge and facial pain for 3 to 4 consecutive days. All those are consistent with acute bacterial sinusitis. Now, other presentations that are consistent with the bacterial etiology include persistent symptoms for equal to or above 10 days without any evidence of clinical improvement, worsening of symptoms characterized by new onset fever, headache, or even increased nasal discharge following a viral upper respiratory tract infection which lasted like 5 to 6 days, and there was initial improvement followed by worsening, what we call double sickening. I would like to remind you that the IDSA acute bacterial sinusitis guidelines state that co-amoxiclav augmentin is the empiric treatment of choice for children and adults rather than amoxicillin. I would also like to add that macrolides and cotrimoxazole should be avoided due to high Streptococcus pneumonia resistant rates, which are in the tune of 30%, if I remember well. I would also remind you that 30 to 40% of Haemophilus influenza isolates are resistant to cotrimoxazole. So Bactrim would not be a good choice. That rules out C, B, and D. The correct answer in this question therefore becomes co-amoxiclav, alternative C. So there you have it, my highly esteemed viewers and listeners. That brings us to the end of this video. If this video benefited you in any way, I would like to humbly remind you to give it a thumbs up, to like it, and to share it widely with your peers, and to leave your comments at the bottom of the video. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. I would like to promise you all that the very, very best is yet to come. So thank you very much for viewing this video and for listening to me. I sincerely appreciate your partnership and your continued support and even your very, very kind collaboration. And I look forward to interacting with you all in the next video. Thank you very much.